I think in starting Amethyst, I think one of the things that we have found in our baseline survey is the launch summaries, and then sort of in the 8 of 10 virtual site visits that we've done so far, we've found a lot of people who are interested in, who are doing really exciting and effectiveness studies and are really interested in incorporating implementation concepts, strategies, outcomes into the work that they're doing, and translating what they're already doing into what we call a type 1 hybrid effectiveness implementation trial. I'll talk a little bit more about what that means in a second. So the outline of what we're going to cover in the next hour, which is a lot to do, is very quickly, what is a type 1 hybrid trial? What are you here to learn about? And then we have 2 panelists who are each going to speak. First, Lisa Levine. Both of the speakers are my colleagues here at the University of Pennsylvania, who are doing really exciting type 1 hybrid trials. Lisa's going to talk about the COMFORT trial, which is around outpatient induction with Foley balloons. And then Nadav Schwartz is going to talk about the reactive trial, which is around antenatal fetal monitoring done remotely from home for high-risk pregnancies. And then we'll have a conversation about how their studies became hybrid trials and how they thought about that, incorporated those implementation concepts into their work. So to kind of show something that I show all the time, which is work from Renad Betis, as well as Megan Leafall, my co-director here at Amethyst. This is the subway map of research. And so we often think of this red area as efficacy research, which does an evidence-based practice work in a really controlled research setting. This is where a lot of our gold standard randomized clinical trials are done, in this kind of red area. We then move down to the yellow area, which is effectiveness. Once we know that an intervention is efficacious in a controlled setting, we then want to understand, does it work in the real world? And so that's what the yellow area is. And then finally, we move down here into the green area, which is the meat of implementation science, which is how do we get people to use our evidence-based practice, right? And so where we're going to be focusing here today is in this area of the green, hybrid effectiveness implementation trials, which really incorporate both the yellow area and the green area. And we'll talk about how you can kind of balance those two things. The one thing I always like to say when I show this subway map is I am a believer that every study, regardless of what part of the research map you're on, deserves some incorporation of implementation science concepts and some planning and designing for implementation. Nothing is going to be an effective intervention or ever be relevant in the real world if we don't take a look at how it might be implemented in various contexts and states. When defining implementation science, I know that we've, almost everyone that is on this call has at least heard some of our baseline stuff around implementation science. And so I don't want to spend too much time on all of that, both through our virtual site visits and the seminars we've held so far. But the things that I think will be helpful as we think about implementation science throughout today's session is that we are talking about some kind of evidence-based practice, an intervention, a practice, an innovation. That's the thing. And then effectiveness research looks at whether the thing works at improving some kind of outcome. And primarily we're talking about like clinical outcomes here, but sometimes patient-centered outcomes as well. And then implementation research looks at how best to help people in places do the thing. Implementation strategies are the stuff we do to try to help the people in places do our thing, our intervention. And then implementation outcomes are really how much and how well are we doing the thing, as well as some other kind of concepts like how much does it cost to do the thing? How acceptable is it to do the thing? How feasible is it to do the thing? So when we think about these hybrid effectiveness implementation designs, there is kind of a terminology that goes around this, which is type 1, type 2, and type 3 trials. What we're going to be focusing on today is the type 1 trials. And this is really all about sort of the balance between how much the study focuses on effectiveness outcomes versus focuses on implementation outcomes. And so down in the type 3 side, that's where we're really primarily focused on clinical outcomes, primarily focused on implementation outcomes, determining the impact of our implementation strategies on implementation outcomes. And then sort of secondarily, we're looking at some clinical outcomes associated with implementation. But today we're going to be focusing, like I said, on this type 1 side of all of this, where effectiveness of the intervention really is the primary goal, looking at clinical outcomes. And really, we're just trying to better understand a context for implementation for further work in a type 1 trial. And so just to kind of show this again, that's why, I feel like what we're talking about here is that sort of every study, even like an RCT, which you're going to hear both the COMFORT trial and the reactive trial are randomized clinical trials, really should be incorporating some amount of implementation research. And even those RCTs can become type 1 hybrid trials. And that's what we're talking about today. And so we'll move on to hear. Yes.
Yeah. Okay. All right, so thank you. This is super exciting. I'm not an expert in implementation science or type 1 trials at all, so I will rely on Rebecca to help me navigate some of the questions that come up, but I certainly can give you the background on this trial, any like clinical aspects to it, and even some of the things that we did talk about when thinking about designing the trial in terms of the implementation side of things. So the COMFORT trial focuses on outpatient cervical ripening. So instead of starting your induction of labor in the hospital, shifting it to the outpatient setting. And we know that there are tons of reasons to do this. One, the rate of an induction of labor is increasing. And we also know that there is a lot of satisfaction with shifting things to the home too. We know that there are healthcare costs and healthcare utilization aspects and benefits to shifting things to the outpatient setting. And then obviously, since COVID, we are really trying to think of novel and innovative ways to get care out of the hospital and into the home. And there's actually a fair amount of evidence and data behind outpatient cervical ripening. This is a Cochrane review from a few years ago that basically says outpatient cervical ripening is feasible. There are really probably few adverse events, and that overall it's probably a safe thing to do, but there weren't any large studies looking at safety specifically. But there were a ton of studies looking at satisfaction, and really a ton of data suggested that there was increased patient satisfaction when starting their labor induction process at home versus starting it in the hospital, with decreased anxiety and overall just patients being really happy with using the Foley at home. And so what do we actually know from a clinical standpoint of outpatient cervical ripening when utilizing the Foley? Just a few of the studies that form the basis of this trial this is one of the earliest studies done by Dr. Sission, who's also my co-investigator on the trial, basically showing that whether you have the Foley in the outpatient setting or the inpatient setting, you achieve the same Bishop score. And this is one of the studies that suggested that doing it on the outpatient side actually plausibly could decrease the C-section rate, although not enough people in this study to look at that exactly. And another study that was done outside of the United States showed fewer hours in the hospital for patients, and overall no major differences in C-section, although a trend towards a difference in failed inductions in the outpatient group. And then here are two additional studies that were done, one in nulliparous patients and one in multiparous patients at UAB. And for nullips, they found a shorter amount of time in the hospital. And again, this overall trend towards a decreased risk in C-section for the nulliparous group. And these are sort of the studies that formed the basis of us really thinking about the question, if we shifted Foley to the outpatient setting, could it plausibly impact C-section risk? But interestingly, when we were going over a lot of this stuff, we realized that there just wasn't much data out there on how to even go about thinking about outpatient cervical ripening with a Foley. And so Tony Sission and myself put together this commentary that really goes through a sort of step-by-step way in which you could implement something like this. But I think, what we very quickly realized as we were putting together the grant, that even with a paper out there like this, there were still so many questions about implementing something like this and how it could actually work in clinical care, that it was really impossible to study the efficacy of an intervention like this without looking at some element of implementation science. So overall, the COMFORT trial, give you a little bit more of the background. So it's a multi-center randomized trial. It's a type 1 hybrid effectiveness implementation trial evaluating the effectiveness of outpatient Foley, specifically on reducing cesarean delivery rates, but also evaluating safety, looking at maternal and neonatal morbidity among nulliparous patients, and specifically also looking at implementation outcomes. So there are 4 sites, 5 hospitals that are in this study, Hospital of UPenn and Pennsylvania Hospital, which are both part of Penn, UT Austin, Utah, and Christiana, and we're enrolling 2,300 nulliparous patients for this. And just to give you a background on like the overall aims of the project, so our first aim is a primary effectiveness aim, where we are really looking at the effectiveness of the outpatient Foley in reducing C-section rates for a nulliparous patient. Our secondary effectiveness aim is looking at safety, so maternal and neonatal morbidity. But then we have an entire primary implementation aim, since this is a type 1 trial, to specifically look at patients and provider and organizational determinants, facilitators, and barriers to actually implementing something like this. And then we also have a healthcare utilization component to that arm too. So from an outcome standpoint, the clinical outcomes that we're looking at are cesarean delivery for the primary outcome, and then maternal and neonatal morbidity, patient satisfaction, labor agentry, and then again, the healthcare utilization parts. And then from an implementation outcome standpoint, we are, the general concept of identifying barriers and facilitators to implementation, and through this, or we are getting at this by looking at acceptability, feasibility, and appropriateness of the intervention, which is outpatient Foley in this context. And we're doing this by looking at surveys, the acceptability, feasibility, and appropriateness surveys of interventions. And we had providers complete these prior to the trial starting. And then patients are completing these surveys before they get randomized. And they're completing it on both outpatient and inpatient induction. And then after they get randomized, we're following up with them and looking to see if their acceptability of the intervention that they were randomized to is any different. And then we are planning for qualitative interviews to really get at more of a mixed methods approach to the acceptability and figure out some of these barriers and facilitators to kind of implementing this into care. I did include this implementation framework by which we decided what surveys we were going to use and sort of what we were going to think about. I am not an expert on this at all, the tailored implementation for a chronic disease checklist, which I think really the concept is it, groups factors that are thought to influence the implementation of whatever the intervention is, really by looking at all of these different pieces, and I think is really going to help us figure out, as we continue to think through qualitative studies, the places to really focus on to get some of the information about barriers and facilitators to implementing this. And I'm also really excited to get that information because I feel like we can probably tweak a lot of the implementation component of this, of the whole study, and how we're actually having this done at all of the different sites. And so I just included a final slide on the progress to date in case anyone was interested. We're enrolling at all 5 hospitals. We've enrolled about 170 patients so far. All the providers have completed all of those surveys, and then we're starting the qualitative interviews. I hope that covered everything that you wanted me to cover.
No, that was fantastic. That's exactly. Thanks, Nadav.
Can you guys see my screens?
Yes.
Great. All right. Thanks for having me, and I'm hoping to learn a lot from of the dialogue myself. But as Rebecca mentioned, like I'm a clinical MFM and clinical researcher. Definitely don't have the study design and implementation background, but learned a ton from Rebecca and her colleagues, and Megan Lane Fall as well as on this project. But so I'm going to talk about remote pregnancy monitoring and how we're trying to innovate care using a new tool. And disclosures are that through this project, where we started doing trials for this specific company, I am now an advisor and I've gotten research funding from them as well. So this is for Nugo Group. So that's just a disclaimer. So we're, one of the big topics we talk about in pregnancy outcomes and adverse pregnancy outcomes is stillbirth. And without going into too much detail, the bottom line is that it's a devastating outcome that is we still have a lot of work to do to try to reduce the incidence and prevalence of stillbirth, even in the US, in more developed countries, but even more so, of course, throughout the world, where there's even worse statistics regarding stillbirth rates. And there's a lot that can still be done. And the second part of it is that there's a significant social and racial disparity related to who's at risk for stillbirth. And one of the biggest parameters, especially one that we study a lot in the Philadelphia region, is related to race. And we see that Black patients are twice as high a risk of stillbirth throughout all gestational ages, and this has been a pretty consistent number, and we have to try to find ways to address that, of course. So in terms of the main thing that we have in our arsenal clinically to reduce stillbirth risks is fetal testing or fetal surveillance, and there's different ways to do that. I'm not going to go into a lot of clinical talk here, but the bottom line is we have different protocols and where patients will have to come into the office for once or twice a week for the last couple of months of the pregnancy to check on the fetus and see if there's any signs that are suspicious, and in that way try to reduce the risk of stillbirth. But again, the key thing there is that the current standard of care is that they have to come into the office. But there are maternity deserts throughout the country and definitely throughout the world where there are it's very difficult to access care. People sometimes may live, even 100 miles away from the nearest medical center, and there are a lot of other barriers to getting to care, especially in the third trimester of pregnancy. When we did internally, we saw in our unit at Hamm that there was a significant discrepancy between Black versus non-Black patients in the percentage of their fetal testing appointments that went as a no-show, where they were not able to come to their appointment for one reason or another. And when we did a small survey, just to not to make too many assumptions, but to just try to get some general idea of where to go, not too surprisingly that the barrier is here, even though we're not in rural America. But transportation costs, issues with childcare, work conflict, these are all issues that makes it difficult for patients to uproot their lives twice a week to come in for a visit. And when in that survey, we asked about the concept of a remote solution because we had already been working with this device, and just on the face of it, without detail, they were open to the idea. So on top of that, I just want to, more recently with COVID, there's a question about the physiology of COVID and how it impacts pregnancy, but there's a large meta-analysis that overall globally the stillbirth risks did go up with COVID. And while there are definitely people working on how COVID may impact the placenta, there's a very prevailing theory that a lot of the issues had to do with, again, access to care. There was a lot of adjustments to care for telehealth in COVID and reducing the in-person visits, but there was no mechanism to actually allow people that needed fetal testing to do this remotely. That just didn't exist. So we have other telehealth things that have shown improvements, but we don't have for fetal testing, and that's what we were going to be working on. So this is just one example of the sort of cornerstone of fetal testing, which is called a non-stress test, when the patient comes in and gets on a monitor to look at the baby's heart rate and contraction pattern. And that's, again, without going into the clinical thing, that's the bedrock of our testing. But again, it's in person. Whereas over the last few years, even before COVID, we had been working with one of the companies that now has an FDA-approved device to allow a patient to do this at home, where under the direction of a care team can get a prescription and have specific appointments to do this from home in the efforts of bringing telehealth to fetal monitoring. So to approach our studies, and I'm almost done, Rebecca, don't worry. We had to ask some preliminary questions before we put in all the work of trying to do a randomized trial. Does the technology work? And so we were a site for the different validation trials of the actual technology, which ended up getting the device FDA approved. We have to ask, is it feasible? Like, just because the device happens, is it feasible enough? Does it work well enough to actually even start our CT? So we had a couple of pilot cohorts that we did prior to a trial, to looking at the success rates, getting some system usability scales from the patients to understand their experience and their acceptability. And we use these cohorts also to train the other stakeholders, like the care team itself, on how to train the patients, how to interact with the patients, and troubleshoot, and then how to take care of them clinically when things are being done remotely. And then, so while NSTs themselves are evidence-based, we've been doing a non-stress test for decades. The question is, will it remain effective when the patient's at home? That's an adjustment. That's still an open question. Can NSTs be effective in improving adherence? So, does it mean just because it's available, will it reduce that disparity in actual compliance or adherence with the regimen? Will patients and providers feel that it's acceptable and appropriate to do this remotely and from home? Will it help overcome the social determinants of health and other barriers that people are facing? And so, the reason why I bolded those things is that, and also, sorry, healthcare costs, which is a whole nother stakeholder, that's a key part to this. But I bolded this because the concept is there's still, even though NSTs was a evidence-based practice, doing it in this manner was still opening up the question of effectiveness. And then you also have the implementation side of things in terms of acceptability and appropriateness. And the combination of the two leads us to the concept of the Harvard trial, or at least that's how, you know, smart people like Dr. Hamm explained it to me. So we worked together towards designing this trial, which is now active, called the REACTIVE trial, remote pregnancy monitoring to improve access. I am the grant PI with Dr. Perry and Dr. Feldman being the trial PIs. And the goals are, again, on the effectiveness side, are we going to improve completion rates overall for patients as well as reduce the disparities from Black versus non-Black patients? What would be the impact on actual outcomes and resource utilization, and then the facilitators and barriers to implementation on a wider scale? And we have, as of last week and a half ago, we were up to 94 patients enrolled. We're looking for 400. And we in the design, we have data collections tools for social determinants of health and surveys related to patient burden and productivity loss. And then the implementation surveys, we have a theory-informed acceptability of healthcare interventions. We have a system usability scale, and we adapted a satisfaction and telehealth survey, and then semi-structured qualitative interviews to get additional feedback from the stakeholders. And that's what I got.
Thank you so much. I hope that gives everyone a starting overview. I know that they could both probably talk about their research projects for a whole day, but we got them to put it down into 5 to 10 minutes, which is very impressive. So what I wanted to open it up to is questions around the implementation side of things, and sort of taking your clinical question and adding implementation questions to it. So everyone can feel free to put questions in the chat and I will ask them, or if you want to raise your hand and unmute, you can. And some of you guys covered this a little bit already, but my first sort of starting question is, why did you think it was important, or how did you decide to incorporate implementation into your research study? And just feel free to add anything to what you guys have already said about that.
I mean, I think it's probably very similar for both of us, but I'll certainly let Nadav answer on his own. But I think both of these clinical concepts had some data already, clinical evidence behind, and certainly the outpatient Foley did. And one of the biggest issues when we talked to a lot of sites as to why they were or were not doing it, one was a concern about the clinical part, like, is it actually safe and does it actually reduce C-sections? But a huge other response was that we just have no way to go about, like, how do we even start to think about implementing something like this? And so I think it just was a natural addition to the study, since we would need to be collecting all of that information anyway.
Yeah.
Yeah, I mean, similarly, I think that we're both dealing with the actual medical intervention, whether it's, you know, is something that's been studied and we're comfortable with. So it wasn't entirely novel, the intervention itself, but it was how the intervention is being deployed and what impact it's going to have on the stakeholders, both subjectively, but even potentially in terms of clinical outcomes. So you have to deal with both the efficacy side and then how people are going, what are the facilitators and barriers. And if you did them sequentially, you know, you're just going to have so much longer lag time before you can actually get meaningful data to actually change care, which is what we all want to do, is impact care. Whereas by doing the hybrid, you're hoping to be able to have wins on both sides of that coin.
Yeah, and I think those points are so relevant to a lot of the types of projects that our centers are doing, which, you know, are around looking at effectiveness of some interventions that are already, you know, again, similarly, somewhat clinically proven, things like anemia toolkits or prevention of primary C-sections, or checklists and toolkits, or, you know, doula partnerships in either the prenatal period or postnatal period. And you know, so I think there's a lot of room for thinking about those kinds of concepts and how, you know, it's definitely adding to the information that we can do to then disseminate these interventions, right, to broader sites. When I think about my next question, it applies maybe a little bit more to Lisa than to Nadav, because your work, Lisa, is at multiple sites. And similarly, a lot of the projects across the centers incorporate, you know, multiple either prenatal care units or hospitals within their research projects. How do you think about the way that each place is going to sort of implement a little bit differently, you know, your intervention, or different either adapt the intervention or different strategies that those places are going to use to implement. How have you been thinking about either tracking that, or if at all, or assessing that, or how does that incorporate, into what you're going to think about the study in the end? Is that too hard of a question? Sorry.
No, I mean, what I'll say is, in terms of some of the strategies that I think that we've been using, I can comment on that. How we're going to track that, I actually, it's a really good question that you're going to have to tell me.
I can think about that starting right now.
But in terms of the different strategies, I think stakeholder buy-in and, training sessions are something that we did. So we had all of the different sites and site leaders meet with the stakeholders at their institutions, which varied a little bit at different sites. Certainly there was always a nursing component, but sometimes they had provider leads and not, and, the stakeholders of the outpatient practices and the labor floor. We created like a what we called a lunch and learn. So it was a PowerPoint that could be modified by sites, where the main site investigator would meet with the different practices and go over the evidence behind it and the nuts and bolts and FAQs of the study and the intervention and everything. I don't know, in terms of the other strategies that I know about from other implementation work you and I have done, I don't, like technically audit and feedback or not like doing the same sense as we do in other studies, but we certainly are following up with providers, reminding them to mention the study, looking and reevaluating at consent rates and seeing what we can do differently to sort of adjust that. I don't know if that really would fall under the audit and feedback aspect. But how we actually track all of that, I don't actually know that we are doing that in a good way.
Yeah, I think, it's an interesting thing because it came up at one of our recent virtual site visits around a much even bigger number of sites that were going to be, dealing with their intervention, their thing, and kind of a even probably broader diversity in terms of how the thing was going to be implemented in terms of strategies or adaptations, and whether, it was worth tracking it. And so, I think that's one of the things that's an interesting question. When we're taking a primarily effectiveness study, that really the goal is to look at these clinical outcomes. The implementation questions don't need to draw away from that. And sometimes it's not feasible to ask every available implementation question in the work that people are doing. But it is one sort of possibility in terms of starting to think about how the thing might be implemented differently, and how it goes better or worse at different places. But we can definitely think about that for comfort as we move ahead. Nadav, what about you? And do you feel like there are any sort of specific implementation strategies that we sort of put into place for reactive and outpatient fetal monitoring? And, how did we pick those? Do we feel like we did discreetly pick them or not?
Well, I think that, I think you always have to think about all the different stakeholders for any intervention and anything you're studying, and which ones you have to prioritize. You can't always get all of them. So, I briefly had a bullet point about the cost effectiveness, because, the healthcare economics of it, in terms of, are payers going to reimburse it, and should healthcare systems invest in it? That's going to be potentially a very big barrier that we may or may not be able to secondarily work on, but we couldn't necessarily make that the goal. We weren't ready for that yet, but we're going to try to, opportunistically get some data for that. And so the other ones are going to be, on the care team side or the patient side. And, since you're recruiting patients, it's easier, I think, to work with the patients on their side of things and the surveys and how they're actually comfortable, because we are trying to center our care around what's best for the patient. But I do think that we have to prioritize that more than prioritizing the providers, because to train every provider in the 2 sites that we're doing on how to use the remote system and how to interact with the protocol would have been a fairly big burden. So rather than, so we have a pool of providers that are involved in the study that will give us some inkling into the implementation aspects of this trial from the provider side. But I think it's we were not able to fully optimize it by having like 10 or 20 providers involved.
Yeah, absolutely. Yeah, I think that brings up an important point, which is like, sometimes implementation strategies when we're thinking of a type 1 hybrid trial are just the things that are like happening kind of naturally, right? They're the things that we realize we're doing only afterwards. And sometimes it's a little bit of like retrospective collection of, what we did to get the thing into place. That is just adds a little bit of information to future implementation, but doesn't necessarily like formally, track any of these things. And so much of what you were saying are, our implementation strategies, right? It's just maybe not as like discreetly planned in advance, and that's okay too. It's still valuable data. I think one of the things, I'm going to bring up Caroline's question first, because I think it's a good one. I'm happy to contribute to the answer. But Caroline asked Dr. Schwartz, you mentioned the outcome for reactive, not limited to within the US, but certainly, globally being antenatal monitoring being obviously a huge issue. Has the intervention been tested in multiple parts of the world? And is implementation science commonly incorporated outside of the States as well? I'm happy to answer the second part of the question.
No, I think it's a great question. So it's also multi-layered in our specific project because, are you testing the idea of a remote non-stress test? Are you testing the specific device? Because there's a lot of complexities for each device, and there's a lot of nuances to the pros and cons of each device. And then there's so many layers of interaction between the patient and the care team. It's not just like an objective on-off switch of a test, like where you got a blood test and now here's your result and you deal with it. There's a lot of like interaction and live real-time type of interactions that the interfaces maybe, there could be fine-tuning of the interface. So since there are so many different levels, this type of thing, you have to sort of separate whether you're studying the idea, can remote monitoring be effective and be acceptable versus the things that are specific to a particular device and also to a particular health system. So, the concept of remote monitoring there are some trials from outside of the US in Europe showing good results, but again, a very different device, but also a very different way of doing medical care, very different thresholds for who gets hospitalized and which patients they would include. So each of these things have to be considered in terms of, as you decide on what is your primary topic of interest, what's your primary research questions, because and then you have to sort of hone it into that one, because you can't just mix and match. So something might have worked in Europe, but it's a different system. Maybe they use a different patient population or a different device. So you have to keep all those factors.
Yeah, and I think that comes to a really important implementation science concept too, which is really the conflict between generalizability and context that sort of comes up in MSCE a lot, which is, we're trying to, so much of what we're doing is trying to adapt an intervention to a specific kind of population or site, right? And, get it to work in that place and figure out strategies that are going to work in that place or for those group of people. But yet we also want to create generalizable data that we can use to implement the thing more broadly. And so sometimes, asking those questions can be really challenging, and figuring out, which pieces are context specific and which pieces are meant to be, generalizable, or, how does analyzing a whole bunch of different contexts help you get generalizable data to better implement. So, it is, it's a constant tension, I would say, in our area. And then thinking about, implementation science outside of the US, there's a lot of global health work in implementation science. And actually at D&I, if you come to the Dissemination Implementation Science Conference each year, there's a huge plethora of work in the global health space in MSCE, because I think that this is actually, those kinds of contexts with less resources are actually some of the most ripe for this kind of work. Like, how do you really get interventions into much more challenging clinical contexts, and really implementation science can really help with that. So it's a great question, Caroline. We're focusing here in the US in the IMPROVE initiative, but certainly there's a lot of global work in that space. My next question is around, if there's so much about doing a study where we're trying to implement something, and sometimes it doesn't work, right? Our study is negative. And so, how does collecting the implementation data that both of you are collecting in your study, how will that help you kind of figure out if, if your study, let's say, is negative, God forbid, is negative, if it was a failure of the intervention to really work on the clinical thing, or is it the failure of the implementation?
I mean, I can say I can answer the that question, but first, a slightly different question that you didn't totally ask, but
Yeah, that's
because
fine
it
too.
is quite possible that, at least in our study for outpatient Foley, it is completely possible that outpatient Foley will not reduce the C-section rate. I don't think anyone's concerned it's going to increase it, although it's always possible. But in thinking through this whole grant, that is a huge reason why we also thought about doing an implementation grant, because we know that it increases patient satisfaction. We're collecting that data, but there's so many studies that show that patients like it better. And there's so many studies that show that it decreases time in the hospital, that even if it doesn't impact C-section risk and morbidity, there's still a lot of benefit in gaining all of the implementation data, because we already know that those other things are impacted. And so that definitely went into the concept of thinking about implementation science. And so then to sort of get to the actual question that you asked, like, how are we going to use that data? I think again, it's depends on what data we end up collecting. And I would say that maybe when we think through these questions, you should help me figure out if we should be collecting any other data. But I think already we really figured out a lot of implementation strategies and tactics as to just how you roll something like this out. For example, it's just one of the things that's not like an implementation outcome per se, but we learned that not every site or place really can do this, have the Foley's placed and have the monitoring happen in outpatient setting. A lot of places have to have it happen in a triage setting. And so, understanding, like, even when you start to think about something like that, that it's not like you can only do this intervention. If you have an outpatient setting that you can have an NST in, you can also do it in a setting that is more of like an OB triage setting. I think that's like some of the stuff that we have learned to date. And I think we probably should think about what other aspects of that would be really helpful. I think, we're collecting the time it takes for each visit, because I think that's really important. We're collecting, how many patients have it placed and then go into labor afterwards, just from, again, a utilization standpoint, and the labor and delivery, holding bed standpoint, because I think that was a big concern and question from like the nursing standpoint on labor and delivery floors.
Yeah. And I mean, I think thinking about, that all kind of plays into like acceptability to the providers, right? Like, where and how it happens and how long it takes and how much resources it entails and cost, and, all of those kind of more concrete implementation outcomes that we take a look at. Nadav, do you have any thoughts on that question? You don't have to.
Yeah, I sort of feel like, this may not be implementation specific, but, you're always going to choose your primary outcomes, your secondary outcomes. When you're powering the study, you're thinking about, are you powered to your secondary outcomes? But I feel for me also, I feel like if it doesn't change the compliance rate, but patients, and it's the same compliance rate, but patients now can do remote care, there's a value to that regardless. And that value can be subjective and qualitative for the patient burden. It could be for the practice in terms of, resources and efficiency. It could be cost. There's so many other potential things. And, I don't think that we necessarily really always power to, and this is more for in your specialty, like you're not necessarily powering to these surveys and to these qualitative parts as much, even if they're secondary outcomes. But on the effectiveness side, when I think more specifically power, you can still have a win on the secondary front, which is super impactful.
Yeah, I think that's all really important. I think it gives your study this value that it might not otherwise have if the primary outcome is negative. Yeah, I think that you're both really speaking to that in a really profound way. And I think there's a lot of opportunity for that in a lot of the projects that the centers are doing as well. I think we talked a little bit about already what implementation outcomes you guys are assessing, and why we kind of chose them. I think that, the ones that we picked for both of these studies, as they're both, RCTs still really evaluating some amount of efficacy and effectiveness, are the kinds of ones that are often done sort of earlier on in a process. But I think that one thing that you spoke about, Nadav, that was really important is like thinking about cost, right? And I think you're both thinking about cost and like, you know, as you know, sometimes it's considered like a further down the line implementation outcome to evaluate. But I think in both of these cases, it's so profoundly important thinking about how this could be upscaled as y'all move ahead. But certainly some of the implementation outcomes, for example, that you're not assessing, right, are things like sustainability or reach necessarily, because we're not quite up to those kinds of things, but those are a little bit more, you know, for interventions that are a bit more down the line. My next question is around like, you know, something that you mentioned, Nadav, which is, and actually Lisa, you mentioned it too, which is that, you know, some of this data that we're getting for implementation during the course of this ongoing RCT has the potential to impact what we're doing in the like processes and implementation strategies that we're utilizing for your RCT. How do you feel like that is, like, how is that working for you? Like, how are you planning to like evaluate that, you know, throughout the course of the study and maybe change things that you're doing in your overall study design? How do you feel about doing that in an RCT at all?
I'm not sure if and you mean within protocol? Try to clarify.
Yeah, I mean, like at some points, right, you're collecting this implementation data in like an ongoing fashion, right? For example, you know, Nadav, in your work, we're collecting surveys and we're going to start interviews, you know, halfway through the study. You know, Lisa, we're going to start provider we're going to start interviews for providers on the sooner end. Like, how do you feel like you might change things based on that information? And if so, like, how do you feel like that is that okay in the setting of an RCT?
Yeah, so I think it depends on to what degree you're trying to change things. I think from a priori, our strategy had been to look at the surveys on the first 100 or so patients and actually use that to inform the script for our qualitative interviews, because we want to get the themes from the patients and say, okay, there seems to be some signal here that patients are commenting on their surveys or seem to have issues with this or that. They're liking, and then you can use that to actually within the protocol create your interview questions, and that's our, you know, that's our plan. I do think though, as you're implementing things, if you see, whether for a safety issue or because you just see that there's a significant obstacle that is addressable, and you know are good about documenting what you did and when you did it, and then in a paper you then explain, okay, this is the data before and after, or you know, I think that's fine, because there's no reason to sort of be handcuffed to a protocol if you think there was an easy fix, as long as you're disclosing and understanding what you're doing going forward. So I think that there is, and now there are, again, not my specialty, but we had looked into it for the grant. There are smart study designs where this is actually built in, just like what I said with the interviews and the surveys, where it's built in, where you're specifically going to do that because you know that these issues will come up, and then you can be much more agile within protocol. But I think even if we're outside of protocol, as long as you're mindful of safety, integrity of the data, and then disclosing and being transparent of any substantive things you've done when you report your data, I think that's appropriate.
Yeah.
Yeah, and I feel like from our standpoint, I think how we'll use the data on acceptability is to hopefully tweak the way that providers are potentially bringing it up to patients, and or the acceptability that the patients find, so they consent for the study. I think we have to figure out why our consent rates aren't as high as we would have expected from, you know, prior survey data that we did to figure out if patients were interested in the study. And I think some of the implementation aspects could relate to that, and then we could like tweak how we're doing part of that.
Yeah, exactly. I mean, I think that's the point I was hoping that you guys would make there, is that there's just so much room for implementation data to allow for your study that might otherwise not look at those things to, you know, have positive changes in your ability to, you know, both enroll patients, but also to, you know, affect your primary outcomes, your clinical outcomes, because you're better implementing, and because you're adapting your implementation sort of plans and strategies and workflows as you go along in the study, which I think is becoming much, you know, like more and more acceptable. I think the idea of like a static RCT where like nothing should change from the beginning to the end is, you know, is is kind of the old idea about how randomized trials should work. But I think that, that there's really no point in going through years of a study, right? That's going to take a few years to complete without even thinking about changing the way that we're going about it if we know that there's better ways to do that. And so, I think that's some of the benefit that adding implementation to, ongoing effectiveness work could be. Everyone, feel free to add questions in the chat if you have them. Otherwise, I'm just going to keep talking, which is, I know that you guys are now working on these type 1 hybrid trials. What have you found challenging about that? What do you think are the biggest challenges of this type of study design as you've moved ahead?
I think my biggest challenge is the expertise, is having people to go to for the expertise. And that's part of the reason why I think the Amethyst group is great. But I don't actually think, at least from my standpoint, that there really are many other challenges with the type 1. In fact, I feel like now, I review a lot of grants on both study sections, but for mentees and colleagues, and I feel like I'm constantly why isn't this a type 1? You could be collecting all of this really interesting implementation, data and doing this. And so I don't think I can really otherwise. The biggest challenge that I have is just not having the expertise myself, which is a challenge.
Oh. Casey, do you want to ask your question?
Sure. Thank you all so much. For all 3 of you, in understanding that sometimes these projects are designed as type 1, hybrid type 1s from the start, but I know thinking through our centers and some of the projects that they've developed, they have ones that they designed as just purely effectiveness trials. And I was wondering if there's any tips or tricks or things that you could recognize and look to for switches to make it into a hybrid type 1, any specific areas to target or questions to ask, outcomes to prioritize, things like that. And I'm sure there's so many different pieces, especially based on the varied research, but I didn't know if there was any kind of general rules of thumb that might be helpful as our centers start to think through that.
Thanks for that, Casey. Nadav or Lisa, do you have any thoughts on parts of your studies that we're doing implementation wise that could be incorporated kind of on the back end?
Yeah, I mean, I think that, I showed that all the work we were doing to try to understand the problem before we even applied for grants and did any cohorts, those surveys where we actually heard from patients about what their barriers to care were, even before, regardless of the device itself. And then those preliminary cohorts where we also learned some of the barriers and incorporating our design. So some of that stuff's obviously a priority, but it doesn't mean you can't add them in. So, it's always nice to have that idea before you design the trial. But once you start the trial and now you're just trying to say, okay, I'm going to add to the protocol surveys. Once I've gotten feedback or understood some of the things to focus on, you add the surveys into the protocol and you're still a type, and then you become a type 1 because you're focusing on effectiveness, but you're layering in the implementation. It's probably easier to do that than for a type 3 where you can't layer in the actual, the actual intervention.
Yeah, I totally agree. And I think Casey brought this up because it was something I was talking about in our most recent center visit, where, they're thinking about turning 2 of their very large effectiveness studies into more type 1 hybrid trials. And I think there's so much room for adding concepts of evaluation for implementation at different points in the study protocol. It doesn't all have to be totally planned out and figured out up front, if that's not feasible. So, thinking about survey aspects for patients or clinicians, I think evaluating, acceptability, penetration of an intervention, sometimes you need to plan a little further in advance, or fidelity to an intervention, right? If you're looking at those kinds of outcomes in terms of, sometimes how you actually put the intervention into practice will impact the ability to collect that data, right? And sort of if you're going to do if you're doing chart reviews or you're doing patient collection of data, of course, knowing that in advance is always a little easier than not knowing that. But, adding things like qualitative interviews or focus groups or surveys later on to evaluate some of the other types of implementation outcomes is not totally unfeasible at all, and really helps, I think, bring the concepts of implementation into an otherwise already planned effectiveness trial. Thanks for that question, Casey. It was on my list. Yeah, I guess my last question in our last 5 minutes before we close is just, do you have any other advice for investigators out there who, similar to you guys, might not have had, formal training in implementation science, but want to incorporate some of this work into the, research that they're doing?
Find good partners.
Yeah, and part of what we're doing as Amethyst too is, not just for those of you, on the call who might not know this as much, not just offering our own services from Amethyst, but also trying to build capacity at your local sites for investigators who are interested in implementation science, or to, in becoming those partners in projects. So we are doing a lot of hopefully training opportunities for investigators locally, so that you will have those people to go to, or those people could be you. Great. Casey, do you have any announcements on upcoming things we should make?
So Friday, February 6th, well, first, thank you to our wonderful presenters. This was incredibly helpful and informative, and we really appreciate your time today. Upcoming Friday, February 16th, we have an introductory workshop hosted by the Mixed Methods Research Lab at Penn on mixed methods and qualitative research in maternal health implementation science. 3 to 5 p.m. The registration link will go out next week. And then next month's monthly seminar will be Friday, March 1st, and will be on writing IRBs for implementation studies. So you can also look